A very warm welcome to you. Thank you for joining us on Health and Wellness. My name is Zaitun Ali and we are coming to you from the Fairview Hotel right here at Bishop Road, Nairobi. And on today's episode, we're talking about pediatric pneumonia. And on set, I'm having Dr. Justice Simba, who is actually a specialist, a chest specialist and a pediatrician consultant at Mama Lucy and JQuat. Karibu sana on the show. I also have Joanina Wanderi, who is a mother to a baby who once got pneumonia at the age of 1 year. And on the other side, I have an audience, and part of the audience is our panelist called Emily Ochieng. She is actually a clinical officer at Huruma Lions Dispensary. Karibu sana, Emily, together with the audience. Karibuni to the show. And we are talking about pediatric pneumonia, and it's actually caused by bacteria and viruses. Daktari, you can expound more on this.
Thank you for having me on the show. So pneumonia, as you have rightly said, is an infection that affects the lungs, and this is caused by different organisms, but mainly the ones which give us a lot of trouble is the bacteria. And these basically are small organisms which you might not be able to see with the eyes. And so you have the bacteria and you also have the viruses. We know the viruses tend to be actually the ones which cause more burden compared to the bacteria as per our current studies. And there are several types, and these particular types, they can be targeted by antibiotics, and that's one of the basis for how when we come to treatment, we focus on antibiotics because there are bacteria which can cause them.
Okay. Yeah. That is well understood. And Joanina, maybe you can tell us your story. What are the symptoms that your child actually showed when you discovered he or she? She was affected with this pneumonia.
Okay. Mtoi alianza ile sasa fever ya mtoi, akakuwa kuna joto sana. Sasa anakuwa lali, ana sweat sana, alafu ile anakuwa na difficult akipumua, unasikia anapumua ile ya mbali anaitafutilia. So mimi sikujua anaweza kuwa na pneumonia, so nilielezea CHP mahali naishi.
CHP meaning
ni community health promoters.
Okay.
Nikamwelezea ile situation mtoto wangu wako, akanipea referral to the Huruma dispensary. So wakati nilifika pale, nilihave kupata daktari, nikamwelezea, I got Dr. Emily. Akaanza kumpima, ndio hapo akarealize mtoi anaweza kuwa na symptoms za kukuwa na pneumonia. So tulianza kumshughulikia hapo na dokta, alinisaidia sana na mtoi akajulikana ako na pneumonia na nikaanza matibabu.
Yeah. So Daktari, perhaps you can tell us what are these stages of pneumonia and what symptoms come about?
Okay, thank you for that. So just as she has said, so pneumonia, when it presents, because it's affecting the lungs, and lungs is what you use to breathe, so you might have someone presenting with a cough, so kukohoa, and then the other thing which can accompany that is that you might have difficulties in breathing, and some children will also have noisy breathing or some abnormal sound coming from their chest.
Wheezing.
Yeah, either wheezing or there could be other different noise, but wheezing is part of the noise that will come from that. There could also be grunting, so that's the other noise which can come from the chest. But most of the time, because it's an infection, then these children will have fever, which will be accompanying the problem. And they might also have other things like being abnormally sleepy. They might have poor feeding. And if you have been very careful, you might notice maybe even the urine output is decreased. Just other things which are showing us that the child is unwell. So that will be...
Urine decrease?
Yeah, because when the child is unwell, so most of the time when children are unwell, maybe the day prior to presenting with the symptoms which you are seeing, they might not have been having the usual feeding. So they will have other things which might tell you that things are not well, is a child who is abnormally sleepy. You see, babies are not like adults, so they will always be playing or active. So if a child is a bit too sleepy, then that day they may not have taken a lot of things, feeds, or they might not have breastfed. So that might manifest by having things like a decrease in urine output. And so those are the first stages. But if it is now becoming worse or it becoming severe, then you might have other signs like even a conversion, because the pneumonia has become, it's affecting more systems, and you're probably not having oxygen everywhere. And you might notice blue discoloration, either from the tongue, the lips, and sometimes with the fingers. If someone is careful enough, they might notice that the fingers are discolored, which we call cyanosis. When we examine them, we'll find that. So that's how they will present. But now when they come to the facility, apart from, so the most important feature of pneumonia is the fast breathing. So when we count the respiratory rate, so that is one of the most important indicators that a child has pneumonia. So we are able to say, for example, we know a baby is up to 2 months, will breathe up to, so if it's above 60, we know they are breathing too fast. If they're up to 1 year, if they are breathing above 50, we know they are breathing too fast, and such kind of parameters which you look at. So how much they are breathing is one of the most important parameters. And then sometimes now, and the other part we look at is, do they have a pool on the lower part of the chest? We call it lower chest or indrawing.
A pool?
Yeah, so because...
What do you mean? Yeah. So
because if you look at our chest, the way our chest is made, the last part which divides our abdomen, or what commonly people call stomach, there is something there called diaphragm. So that diaphragm, it is attached to the lower part of the chest. So when you are breathing normally, there will be no pull. But when you have pneumonia, because someone is struggling to breathe, then the diaphragm pulls the chest. And then by just exposing the child, then you'll be able to see the lower chest or indrawing, which is another important sign. And nowadays, now the other things we are able to do in hospitals, we are able to measure the oxygen saturation. And I think that became very common during COVID-19. People are able to do their, what we call the SpO2, the oxygen saturation. So those are the other things we look at. And then we are also able to listen and feel whether there are any abnormal sounds, like the wheeze, which you mentioned, crackles, and all that, which are the other things we will notice in that child.
Okay. And perhaps I'd like to talk to you, Emily. The first day that Joanina brought the kid, what were the symptoms, and what was the case for this one?
Okay, thank you very much. She presented to our facility with a sick baby, and normally when you come, we have a reception whereby we do booking, and at the booking, that is where we have triage. Triage is where we do emergency, like we have to do in a way that there's a way that here in triage we have to select, give them priorities. So looking at if there's a problem, especially there are things that we call danger sign. So you look at this baby, and if he or she falls in a category whereby there is danger sign, and some of the danger signs are maybe unconsciousness, maybe not feeding, vomiting everything, and maybe if a mother or the guardian says history of convulsion, or maybe you've witnessed one convulsion during this illness. So if you notice there is one or two of the things that I've just mentioned, that is a baby that you'll give priority direct to the emergency room, and that is when you'll be able to start managing. But with the case of Joanina's baby, we categorized it under non-severe pneumonia, because after triage, it wasn't falling under any danger sign. So the baby had difficulty in breathing, there was fever, and there was also cough, and refusal to feed, like on and off. The baby could only just breastfeed. So the baby was taken in, and we assessed the way Dr. has just said, looked at the chest, you look, listen, and feel. So during now examination is when I found out that there was lower chest wall indrawing and fast breathing, as compared to the number of the age that the baby is supposed to be breathing at that moment. So I was able to diagnose this baby with non-severe pneumonia. Yeah, because the baby wasn't falling anywhere with any severe or danger sign. So the baby didn't fall under severe or any severe disease. So in non-severe pneumonia, in our facility, what we go ahead and do, We sometimes also do complete blood count, maybe to check whether it's bacterial or maybe viral.
Viral, yeah.
Yes. So according to the test I did, it was bacterial, because you could see at least the immune cells, actively fighting, and now that is a sure indication of a bacterial. Then now the first line currently we manage with dispersible amoxicillin, high dosage, depending now with the weight.
So now this is an antibiotic?
Yes, amoxicillin dispersible. Now we call it amoxicillin DT. Yes.
Okay.
Thank you.
Thank you so much. Daktari, are there stages of pneumonia?
Some of them we are not able to see. We call them pathological stages. So pneumonia moves from one stage to the other. So those stages are divided into 4, where you start from a stage we call the stage of edema, such that if you are to look inside the lungs, you will find there is more swelling and maybe just more fluid, which is being seen in the area which is affected. Then moves to another stage, 2 other stages which have complicated names, what is called red hepatization, then gray hepatization, then now the pneumonia will resolve. So that's inside the body what is happening. But in terms of clinically, when you look at the patient, then just as my colleague has said, in the initial part, we want to look at this child, are they in severe pneumonia? So we classify pneumonia into 3. So there is the severe pneumonia, the non-severe pneumonia, and then there is the part where we say no pneumonia, which is basically a child who has come in with a cough, difficulty in breathing, but they are not breathing fast, so we think it is maybe an upper respiratory tract infection or something. But also, so that's what would happen. So initial part, we'll assume you're having just a simple pneumonia. It could be just a simple pneumonia, could be non-severe or severe. However, pneumonia can become complicated. And usually this one, so in the initial part, we assume you are going to follow the same tract or the same road as any other person. But by 48 hours, if we think, if you look at the patient and they are not improving, then we have to ask ourselves, is it complicated pneumonia? And this means that there are other things which are happening, which you probably need to do different things, because pneumonia can complicate in that you might have air leaking from the lungs to the part in between the chest and the lungs. We call it pneumothorax. Or you could also have some fluid. So like you get pleural effusion, which now those ones require slightly different management as opposed to the simple or the straightforward pneumonia, which has the patient has come and doesn't have other issues. So that's basically what, when you look at the pneumonia, you try to classify
stages.
Okay.
And Emily actually mentioned about the danger zone. So in terms of pediatric pneumonia, what is this danger zone specifically? Okay,
so when you look at in an effort by the World Health Organization to try and help us as healthcare workers in a setup where Emily works, where you have a lot of patients who are coming in, what are these simple signs you can look at which will tell you this patient is in danger? In fact, when you talk about the danger, we actually mean danger of dying or danger of having a bigger problem or complicating. And so the signs we are looking at usually will tell us whatever illness this patient has, whether pneumonia or another thing, if you are abnormally sleepy, if you are conversing, if you are vomiting everything, if you find the oxygen levels are less than 90%, then we know you are in danger of having a bad outcome. And that's what now we try to prevent by instituting treatment and care very early and being a bit more aggressive as opposed to another patient who doesn't have a lot of issues.
Joanina, and let's talk about when you now reached the hospital. What kind of treatment and tests was your baby done for? And talk about also the recovery after that.
Okay, after kufika pale hospitali, kuna ile kipimo ya kwanza mtoto lazima angaliwe kama joto iko juu sana. So walipima kama kwanza joto iko juu, then wakaangalia breathing system yake vile iko, na then nikatumwa kwa lab. Kuna test ilifanywa kwa lab. After hiyo test ndio ilionyesha the symptoms zenye zilikuwa za pneumonia.
Okay.
Yeah.
Okay, matibabu ilikuwaje?
Matibabu yenye alifanyiwa pale, after hizo test, kuna dawa zenye alipewa pale na kuna zenye aliinjectiwa on the spot.
Okay.
Na kuna yenye alipewa ya oral ya kupunguza ile joto.
Okay.
Yeah.
Na vile mlifika nyumbani, recovery yake ilikuwa haraka ama alikuwa na respond to the medication haraka ama bado alikuwa na show the symptoms?
Respond, but it take time.
How long?
It take almost 2 weeks.
Okay.
Yeah.
Okay. So back to Emily. Talk about the treatment process and the medication, especially that you give to her.
Okay, thank you very much. And the first line that I mentioned earlier is in non-severe pneumonia, we give amoxicillin dispersible high dose. And this high dose, it comes in 250 milligrams. So that is where we calculate. So depending with the weight, because her child was falling under, it was around 10 kilograms. So that one you give high dose of amoxicillin, that is 500. And it's taken twice a day. Yeah. That is after every 12 hours daily. Then at the facility, we had to prevent convulsions because the fever was spiking. So we had to give Gasset. Now this is also something that we use to calm the, bring down the temperature. So it's inserted at the anus of the baby. So it has to be calculated also according to the weight of the baby. Okay. Yeah, it brings the temperature down. So after giving something for the temperature, and also at the facility we give a start dose. We demonstrate how it's given. We gave her 2 tablets, start, whereby it's put in a cup and just a little bit of water. Okay. Yeah, so you wait for the drugs to dissolve because it will dissolve inside that water, and you make sure the baby finishes it. So while giving your baby, you have to confirm that the cup is empty. You don't leave any particles in the cup. So that is that dose you demonstrate to the mother, and then they have to make sure that they can also do it at home. They have to confirm to you. And then in non-severe pneumonia also, we give them 24 hours return date. After that 1 day, if the baby doesn't improve, you tell them to bring back the baby so that you see if she maybe have given the baby in a correct way or there is a problem. So you have to find out how did you give the drug at home if your baby is not improving. Yeah. So if there is any other maybe severity as compared to yesterday, now that is when we now look for, even if maybe kind of danger signs. But even if there is no danger sign, but the child doesn't show any signs of improvement, we actually try and encourage the mother. And then we might also give a start dose if we feel the baby needs a referral. Maybe the oxygen level are now becoming low that we cannot manage at a dispensary level. Yeah. So we now plan for referral, but we give a start dose of maybe Expen and gentamicin, and then look for a referral system. And we thank God we also have partners who are partnering with us there. We get ambulance free of charge. So if we don't get from the county government, we get at MSF. So we get those services, and the nearest facility that we refer to is Mama Lucy. I'm able to get a feedback from the patient, not Daktari. Okay. He or she will come because after discharge from Mama Lucy, she will be told, now because you're feeling better or improved, now you will take your baby to the nearest health facility that you used to go to for any other further, if at all there is you need further clarification or you just need a review. Okay, you can hold it there. We just want to take a short commercial break, and we've learned a lot about the symptoms, about the medication and treatment. So after the break, we'll come back with more. Is there prevention? Is there a vaccine to give the baby? So remember, we are right here at Fairview Hotel. This is Health and Wellness. Stay tuned.
Welcome back. If you've just joined us, remember this is Health and Wellness. My name is Zaitun Ali and we are coming to you from the Fairview Hotel right here at Bishop Road, Nairobi. And we are talking about pediatric pneumonia. On set, I have Dr. Justa Simba, who is a chest specialist. I also have Joanna, a mom to one of the survivors of pneumonia, a 1-year-old baby. And also we have our clinical officer, Emily Ochieng, on the audience side. So karibuni back to the show. So Amelia showed symptoms and you went for treatment, but you had mentioned that the treatment was not responding as expected. It took a while longer. So talk about this.
Ili take long kama joto dilikataa kabisa kupungua.
Yes.
Juu mi vile nilichukua mtoi nikarudi kwa hao, mi sikutoa mtoi manguo, mi niliendelea kumfunika. So sikulia la hizi nguo zinamuongezea ile joto. So after kumrudisha hospitali ndio daktari akanielezea mtoto akiwa anapandisha joto wanapunguziwa manguo. So mimi kwa akili yangu haikunionyesha nguo zinaweza cause joto ya mtoi kupanda. Then nikakuwa saa zile mtoi amekula kitu, amelala, amevomit. So mimi sikuona ati naweza mfeed tena. So mimi nilikuwa nagojea tu mtoi amelala na alivomit, sasa atakiamuka tu ataendelea.
Oh no.
So yani sikuwa na ile information ya kutosha. Akisha lala juu alivomit, akiamuka nafaa kumfeed tena. Unaona, sasa ndio nikaelezea daktari akaweza kunielezea saa zile mtoi amevomit ile kitu alikuwa nayo, akisha lala mke nafaa kumfeed tena, at least akuwe na ile nguvu kidogo inabaki kwa mwili.
Understand. And according to UNICEF, they had a research saying that more than 800 kids worldwide every single year die because of this pediatric pneumonia. And I bring it to you, Dr. Justa. So what is the mortality rate as per now?
Okay, thank you for that. So just to reiterate what you have said, pneumonia is actually the leading cause of death in children. And you find that if you take all the under 5s, slightly above 10% of them will die from pneumonia. And it's actually worse if you now take the 1 year to 5 years. 1 in every 5 children who die will have died because of pneumonia. So it's actually a leading cause of death. There has been efforts which have been put, and so the number which we are now, which is less than 1 million, maybe a couple of years ago, that number was above 1 million. So there has been a bit of decrease. It's not as fast as what probably people how would all want it to be. There's a lot of ongoing work to see what else we can do. There are colleagues within this country who are doing a lot of research to try and see whether we are able to change the tides in terms of that mortality. And so that's where probably we are at this point. Things are improving, but not as much as it's supposed to be.
And are there preventative measures? Is it a vaccine? How do we prevent this?
Thank you for that. So pneumonia, there are main things, there are a few things which are supposed to help us prevent pneumonia. And one of them I'll start with is nutrition, which is feeding the babies. And the most important thing which has been noted to improve and prevent pneumonia in the future is breastfeeding. So just breastfeeding that child for the first 6 months gives them such an armory against that pneumonia, which is so important. And ensuring that when these children now are being transitioned from breastfeeding alone at 6 months, we are using the appropriate nutrition, and we probably reduce a lot of myths around what, long time people used to say you can only take proteins after 2 years or things like that, because that makes the baby have a lower immunity. And so efforts to ensure that nutrition is okay, doing that growth monitoring. So anytime you have a baby, taking them to hospital and having that weight. Remember, apart from the vaccines, we are going to come into in a few seconds. That monitoring, anytime you see the weight is not going as per the potential of that child. So there is that road to health, which is in that booklet, which the Minister of Health has been able to make sure it's rolled over everywhere in the country. So if a baby is not tracking appropriately, then we need to ask ourselves, what is the problem? Because we know that babies who have malnutrition, unfortunately, malnutrition contributes 50% of the mortality. So anytime of the deaths, basically.
Yeah.
So anytime you have children dying, 50% of them have a form of malnutrition. They could be having rickets, which is so common in urban setups around Nairobi, the Mount Kenya region. A lot of children seem to suffer from rickets. The other things now is making sure they are treated appropriately for diarrhea. So the World Health Organization has a strategy which combines both pneumonia and diarrhea. And we know if a child is going to suffer diarrhea and they end up with those problems, it staggers their growth, causing them problems, then that leads to a problem. So just making sure they get the ORS and the zinc, which is going to help them. And then the vaccines. Okay. So the government has, with partnerships from outside the country, has done a lot of work to ensure that out of the vaccines we receive for our babies, there are probably more than 5 vaccines which actually try to help us reduce pneumonia. So there's the one which is commonly known, which is called pneumococcal vaccine, but there's a lot of other vaccines. There's the Haemophilus vaccine, the measles vaccine, the TB vaccine, the BCG. We didn't mention, but TB is also a form of pneumonia because it's affecting the lungs. So even that will prevent us from having those issues. So basically, a child should get those vaccines from when they have been born, and that helps them to prevent pneumonia. But also there's a special category of children who might have other issues. They might have other chronic problems. Let's say sickle cell disease, for example. They have renal disease, maybe they have asthma, maybe they have had chemotherapy. Then they need other vaccines on top of the ones we refer as the routine, the ones given to each and every baby, which usually will be given from like 2 years and all that. But also we give preventive treatment. So for example, if a mother has HIV and that is either passed on to the baby, that particular baby is put on a prophylaxis. So they are put on Septrin, which is another type of antibiotic, and they take it every single day to prevent a particular pneumonia, which affects that group of children. Is commonly referred as PCP, which is pneumocystis pneumonia. And the other things, of course, now is to look at the broader picture of now preventing HIV, because those children who will end up with HIV, they are more likely to end up in pneumonia because their immunity has gone down. Because that's why we started with the nutrition. Appropriate nutrition will prevent. Then there is the other thing which commonly now becoming a big thing, the environmental pollution and our quality of air.
Okay.
So we know that in our African setup, we have had these photos where we see mothers with the babies at the back and they are cooking from a very smoking, using the firewoods and all that. We know that causes a lot of problems. And I am aware, practicing where, as I mentioned in Mama Lucy, it's part of the teaching also for JKUAT where I work. We know that there is a lot of efforts to try and make sure, even if the person is going to use a cheap fuel, but they are avoiding the biomass, which causes a lot of smoke, causes a lot of injury to the babies. And also avoiding the smoking, the cigarette smoking.
Yes.
That is a big thing. And I know sometimes people say I smoke outside, then I come inside the house because the baby, so that doesn't work. If you are carrying the smoke, unless you leave your clothes outside there, you have carried the smoke, doesn't help the baby. And the other things are really to urge the industries a lot of that, to make sure whatever they get out of their factories is safe for the environment, because at the end of the day, those things will not affect the babies, affect the airways, and the other things which maybe has come to a close on how to prevent. Also trying to address the babies who come before their time. And that's a difficult topic. Preterm babies who have been born before their time, they are more likely to suffer from pneumonias. So having strategies which try to make sure we can try and reduce that. We might not be able to stop it completely, but trying to stop that. And the other thing maybe I should mention is just that early treatment.
Yes.
So that early treatment is part of the prevention of the whole thing, because patients might go into complication if we don't start early. So those are some of the preventive strategies which you should be able to use and will help us.
I think there's an injection that actually a mother is given before the baby is born, just to strengthen the lungs.
Yeah.
Can that also help?
Yes, so yeah, so that helps, because we know that babies who are, let's say, born preterm and then they end up developing, so they are, when you get that injection for mothers who inevitably are going to deliver before their time, so they are given an injection to try and mature the lungs, to prevent them from getting a condition which you call respiratory distress syndrome, which is basically preterm lungs.
Yeah.
They're not able to breathe. Now we know babies who have suffered that condition are more likely in their first year of life to get a lot of recurrent pneumonia. So yes, that would also contribute in preventing that.
Okay. Yeah. So at this juncture, I want to give an opportunity to the audience to ask the questions to this other side, and also to our panelists right here, Emily. In case anyone has a question, feel free.
Niko na swali. Pia mimi nimepitia hiyo changamoto ya watoto kupata pneumonia wakati walikuwa wadogo, sasa ni wakubwa. So kwa sasa niko tuna watoto wadogo, na si wale nimezaa, ni watoto wangu. So kuna vile pia wanapata hiyo changamoto ya temperature. So kwa kawaida huko kwa mtaa tuna hizo vipimo za thermometer. Tunapima na mkono. Tunaingiza mkono kwa mwili ya mtoto, unashika ikiwa na joto. Ni moto. Unaona kuna moto. So tunaenda tunachukua towel, tunaweka kwa maji, tunakamua, tunamfunikia. So sijui kama madaktari zetu tunaona kama tunakuwa tumefanya kitu mzuri ama tumekosea mahali. At least tujibiwe, hiyo ndio iko common sana.
Swali lako linaenda kwa nani?
Nenda kwa Daktari Simba.
Sawa, thank you so much.
Okay, thank you for that question. Asante sana kwa hilo swali. Basically, joto ni kitu ya kutuambia something is not okay. Yeah. So it is maybe the way this God or how we are able to be communicated, something is not okay. So a lot of debate is actually about ufai put a lot of effort to make sure mtoto hana joto. Sababu joto inakuambia kuna kitu haiko sawa. Na kama iko sawa, unajua mtu mkubwa anaweza chukua joto akunywe Panadol mara moja na hiyo ni sawa. Maybe by the following day kama haijakuwa sawa utaenda hospitali. Lakini tunapoteza watoto wengi sana kwa sababu hii kitu ya joto watu wanafikiria maybe ni meno imeleta.
Yes.
Na mimi nimesoma vitabu mingi sana, tujaiona hiyo kwa vitabu zile tunasoma ya kwamba meno inaleta joto. While we know there are maybe theories which might attempt to explain, the truth of the matter is teething is a normal process, except when it is complicated.
Okay.
Except when you probably have something else. When the teeth is trying to come out, it has something called it has an inflammation. But otherwise, is a normal process. Then other things grow in your body, the hair, the teeth, the nails. There are so many things
and
you
grow, don't get fever.
And you don't get fever. So efforts, we should not put a lot of effort to reduce joto. Lakini joto, just kujibu hiyo swali kabisa, unaona mwili ikikuwa saa zile temperature inaenda kupanda mtu ana shake. Sasa ukiongezea kitu baridi ita-interpret bado ndio tunahitaji kupandisha temperature. So mwili, because it's somewhere uko kwa brain, tunaita there's a particular point temperature set point, ndio ina-interpret what is kwa skin. So kama temperature inapanda, mwili ina-interpret tunafaa tu sweat, tunafaa tu. Ukiongezea baridi na hiyo kitu ilikuwa hata common, na maybe ilianza upande wa hospitali inaitwa tepid sponge, ilianza hiyo upande, lakini siku hizi imejulikana hiyo kitu haina science ile mzuri. Na naambianga watu the easiest way kujua medicine uchange kila wakati ni COVID-19.
Yeah.
Kila mtu aliona vile wakati wa kwanza tukua tunakaribiana, tunarusha watu kama ni kuzika, lakini with the time tukadiscover hiyo mwili hata ikiwa hapo iwezi kuletea shida. So hizo vitu zingine zimebadilika. So joto kwa mtoto, tafadhali enda kwa hiyo hospitali iko hapo karibu. Wakiangalia waseme ni sawa, ni sawa. Kama kuna kitu ya kutibiwa, kama ni antibiotic, mtoto atapatiwa, lakini tusijaribu sana kuiweka chini.
Okay, thank you for that answer. And I want to give this question to you, Emily. You had shared with me, is it called a patient management form, or is it a child management form?
Sick child management form.
Sick child management form. So how does this work?
The sick child management form actually helps us, it has really improved our services as compared to initially the way we used to just randomly triage after triage, or you could just ask mtoto anakohoa and then the symptoms after symptoms.
Yeah.
Sometimes we you could just go through the normal process, but maybe it had poor documentation. So you find that maybe I've referred this baby to Mama Lucy, and the documentation is not it's not appropriate. Some things are missing. But using this sick child management form, it covers from 2 months to 59 months. So it's a summary of everything that has been done from registration. If at all at the triage you are able to get a danger sign, it's documented there. And then nutrition-wise, it actually covers the whole setup of level 2, because it also have the HIV part, it also have the TB part, it also have the diarrhea part, ear, nose and throat part, especially the ear, because all those are causes of fever. Somebody might mistake that any fever might be from maybe pneumonia. And then it also covers the diarrhea. Actually, the first key point, the tool was actually introduced, and my facility participated in this in implementation because it was a pilot site. The government has actually not given us the okay, and we are still practicing it, using it, but it has actually shown a lot of improvement using the tool. And it started with 3 facilities, and currently I think half of Nairobi County, some of the facilities are using it. But now, as compared to the way we used to manage before, it is a bit detailed and it covers everything. And I like the part of where nutrition comes in. And I normally tell my guardians or parents, when you're bringing a sick child to the facility, make sure you have the mother and child booklet.
Okay.
Because
just to check the history.
Yes, from birth, during pregnancy, and maybe this baby, the person who is bringing this baby to the hospital is not actually the parent. Maybe just a neighbor aliona mtoto akiwa mgonjwa akasema, let me just help this neighbor, the baby might look sick. And then you end up looking at, you're not going to ask this mother or this caregiver who has brought the child to the hospital about the HIV status of the mother. It's actually in that booklet. And it's easy for you to know, maybe look at the test that has been done. If this is a child that is exposed, you are able to know accordingly and how you're going to manage, because this is a baby that you're not going to put actually on amoxicillin DT.
Okay.
Yeah.
Okay, thank you for that. And I want to give a chance to one more question. One more person who has a question. Yes, thank you.
Malizeni tena.
Salama.
Swali langu inaenda kwa Daktari Justus. Amesema hizo preventive measures na kuna ile ina affect watu wa kijiji kama smoke. Na mostly kama hivi ile economy sasa imeenda juu, napata uko na gas lakini imeisha.
Kweli.
Inabidi utumie ile stove. Utafanya nini?
Asante kwa hilo swali. Sababu vile na run clinic Mama Lucy specifically ya lung disease, na so nimeinteract na watu wa kutoka community ama kijiji kama vile unasema, na wamenifahamisha hata kuna option nyingine, sijui kama inaitwa coco, and naona kama hiyo ni kitu yenye, because naambiwa hiyo unaweza enda kununua na bei yenye inakaa ni kama unaweza pimiwa ile yako ya saa hizo. Na nikalia, sijafanya utafiti kabisa, lakini with my part of my team I work with, I think it appears ni kama ni kitu inaonekana inaweza kuwa suluhisho. Kwa hiyo na because we agree na tunaelewa ya kwamba economy kuna vile imeendelea kwa sasa, na I think unaweza angalia kama hizo option, because I think hizo zinakuwa afadhali.
If that's not an option, can one just put maybe the jiko or the stove outside or somewhere where
Yes.
the baby cannot
Yes. Yeah.
come into contact?
Yes,
Okay.
thank you. Yeah, that's actually a very, and making sure madirisha imefunguliwa
Yes.
zaidi ya hiyo.
Yes.
Making sure kama watoto haupiki huko nje, lakini wako hapa kwa mgongo, sababu tena watakuwa wanaendelea tu kuchukua. So but hiyo ni njia moja mzuri yenye inaweza fanyika. Asante.
Asante sana. Thank you all for being a part of this conversation. Georgiana, asante sana for sharing your experience. I hope baby is okay right now.
Yeah, kwa sawa.
Asante. Also, Dr. Justus, for the information. That was amazing. We've learned a lot today. Tumejua hata meno haileti fever. Thank you so much also, Emily, for the insights. Now, wamama wetu mpaka wamekuja na watoto. This is clear evidence that they are healthy and strong, and pediatric pneumonia is not a deathbed. So we aim at reducing this mortality rate by early treatment, early diagnosis, and this can work as well. So this has been Health and Wellness. The SMS line remains to be 22151. You can just send in your questions and find us on our socials at KTN Home, at Zaitun Ali, on all platforms. Remember, the hashtag on X is hashtag Health and Wellness, hashtag KTN Welcome Home. Thank you so much for joining us. Until next time.